All right, welcome back, everyone. It's nice to have you back. We will now continue on with the amazing Mr. Dr. Christopher Wang. Um, we'll now move into what is a very, very timely session in the Canadian healthcare space, and has been at the forefront of actually trans advocacy for a very, very long time. So, without further ado, I will pass it back to Dr. Christopher Wang.
Thank you again. Let me just share my screen. All right, great. So for this next topic, we're going to zoom in a little bit more on screening, different screening protocols, as well as the actual procedures for them. This is, as Chris mentioned, a very important topic, and especially given some recent media of colon cancer rising in perhaps more prominent people. And so we're starting to get a lot of questions about colon cancer screening. Hopefully this can provide everyone with a little bit more information. Um, so to build off of our last session, I'm going to pick up where we left off in terms of talking about some of the statistics that we are seeing here in Canada. I'm going to then focus a little bit more on specifically screening statistics in terms of what kind of tests are being done, whether they're being uptaken by the population, what some more details are about that. And I'm going to talk about the criteria that we currently have here in Canada for screening for colon cancer. I'm going to delve a little bit into provincial data and provincial differences. And finally, we'll end off with going through the actual procedures themselves, whether it's for FIT testing or colonoscopy. Those are the two main forms of screening that I'm going to be talking about today. So these two slides are just repeats from my last talk. So apologies if you've heard this already, but this topic is very important because in the States, it has recently been found that colon cancer is now the leading cause of death in people less than 50 years old. And this is with American data, but Canada is always quite quick to follow suit. And so I suspect that in the upcoming months, we might start hearing a little bit more about this too. And hopefully it'll be a changing landscape in the right direction. As I presented, there are many factors that have led to overall decreases in other cancers, such as reduction in smoking, leading to a decrease in lung cancer, improvements in screening modalities for breast cancer that have led to that decrease over the past 10 years. But colorectal cancer, unfortunately, appears to have increased in the 10 years, and this is incidence. Now, I should say that things like reducing smoking, lifestyle measures that have helped other cancers do also help with colon cancer. And so not to dismiss the importance of lifestyle factors there, but there is clearly something that still needs to be investigated in terms of explaining this concerning trend. And as I said, Canada is always quick to follow suit. Anytime something in America gets highlighted or published, a Canadian study is quick to follow. And this is a recent study put out in 2026 that is published in the Journal of the CAG, so it's the Canadian Association of Gastroenterology. That is our main society as gastroenterologists, and we have a journal. And I found this article quite recently. There's a couple of big names on here, including many of my mentors from Edmonton. And so this is a Canada-wide survey, and it's good to see many provinces highlighting the importance of this as well. And so basically, the aim of the study was was to explain or to predict this change and how we can best respond. And so there's no arguing that this incidence of colorectal cancer has increased among Canadians under 50 years old, as we saw in the previous slide. And this group used basically a series of predictive models to see what would happen if we followed the states and if we lowered our screening age to 45. This is again for asymptomatic average risk individuals. So we're not talking about high risk individuals. This looked purely at incidence, so first ever colonoscopy or FIT test, what would happen if we decrease that to 45. And I think the argument is quite persuasive. Using this model, they predict about 15,000 cases of colon cancer that would be detected and therefore caught early. They predict about 6,000 less deaths. And overall, based on economic models, this would lead to net cost savings in the system. Now, obviously, like the data here seems pretty obvious. If we start earlier, we're going to catch more. But I think more studies like this are needed because sometimes just one study like this may not necessarily be enough to move lawmakers or the Canadian Health Agency. And so we definitely need more studies that talk about these seemingly obvious trends, but I think highlighting these and being aware of these when they come out does increase our voice in being able to advocate for our younger patients. This is a little bit of the data actually captured within the article itself. And so this is the age-specific colon cancer rates between 2003 and 2022. And this is with Canadian data exclusively, which I also feel is lacking in general. A lot of our studies come from the States, but to find a good Canadian study with Canadian data is a bit rare. And as you can see in the green lines, this is people we are already screening. So people 50 to 54, 55 to 59, 60 to 64. This is what happens for these patients if we do a colonoscopy in that age group at that year. So back in 2023, if we did a colonoscopy for someone between 50 and 54, we might find an age-specific colorectal cancer incident about 50 per 100,000 colonoscopies that we do. And then that number does go up with age. And so if a person at 60, 64 got his first colonoscopy back in 2003, the age-specific incidence rate would be quite a bit higher. I wanted to highlight a couple of encouraging trends, so it's not all doom and gloom, but you can see that, first of all, the green lines are converging and they are decreasing, which is very good news, meaning that in today's modern day, 2022, if we do a colonoscopy, you're less likely to catch something between the age groups, and overall the incidence is decreasing among the age groups, which is good news. The red is now what would happen for people who we are not actively screening. So you can see back then we would very rarely do colonoscopies for people between 45 to 49 or even younger than that. But if we did do them, we do catch cancers. And unfortunately, that red line is increasing because we are, as mentioned, seeing more and more cancers in younger people. And the three lines are also not converging. They're not getting closer together, meaning that if we were to start even at younger ages, we might see proportionally similar amounts of cancer. And so this was an argument that they used to justify lowering the screening age to at least 45 to 49, but potentially even lower to help bridge that gap. if using predictive models, as I said, they looked at the detection of colorectal cancer cases if they were to lower the screening age to 45. And you can see that there's a bit of a ripple effect. And this phenomenon happens whenever we lower a screening age. So when we lower screening age, it not only benefits the people who are actively in that age group, so for those people who are 45 to 49, but there's a ripple effect moving forward, meaning that as they age, as they get older, there's actually less cancer in them because they have been screened at an earlier age. And that's what these two charts are trying to show, is this ripple effect of what would happen if we were to lower the screening age. And it's a pretty large margin, which is an argument for decreasing that age here in Canada. And so, as I said, I think we need more of those types of articles. As we get more data and as we develop more sophisticated predictive models, hopefully we can continue to add to that voice of lowering that age here in Canada. As for now, these are our screening guidelines, and I was a little bit surprised, honestly, preparing for this talk. I had to dig quite far back to look at these guidelines because they have not been updated in a very, very long time. In 2016, these are the guidelines from, I think it's the Canadian Association of Gastroenterology, and these are, believe it or not, some of the more, these are the guidelines that we are currently following. Back then, they compared it to the guidelines back in 2001, so even earlier than that. They looked at the Canadian Preventative Task Force, and then they compared themselves to these states. So these are, sorry, this is the screening guidelines put out by the Canadian Task Force on Preventative Health. And so we're looking at the middle column here. That's currently what we follow. Patients 50 to 59, we are screening them. 60 to 64, we are screening them. Above 75 years old, we are typically not screening. And in brackets is the strength of the evidence that supports screening in that age group. And so back then, we did not have actually very great evidence for screening people between 50 to 59. That has clearly changed because we now regularly do that. But the bulk of the evidence back then in 2016 was for the age group between 60 to 74. Back then, again, we had two options, the FOBT or the FIT, and I'll talk a little bit about why it's almost laughable that we're still thinking about FOBTs in this day and age, but that is still the most updated procedure we have. And then you'll notice that at the very bottom for colonoscopies, it was not typically recommended for an average risk individual. And we'll talk a bit about that later. Comparing that to our counterparts down south, they had very good evidence for screening all age groups, and they typically have recommended that in place of a FIT test, a colonoscopy could be offered as well. Notice that they down south are doing FIT tests every year, versus here in Canada, it's still typically recommended every 2 years. This is from the Canadian Association of Gastroenterology, and it describes the screening intervals based on the genetic risk. And so, as I mentioned in my last talk, that is typically what we're going by right now, because we know that genetic first-degree relatives who have colon cancer certainly increase the genetic risk. And so this is currently the intervals that are recommended. So starting at the very left of this chart is the patients with the highest risk, those with 2 or more first-degree relatives. That's what FDR stands for, with colorectal cancer. So if a patient comes to me, has 2 or more relatives with colorectal cancer, we are definitely doing a colonoscopy. We are definitely screening them. And we are starting at age 40 or 10 years younger than the age of diagnosis of the first degree relative, whichever one is earlier. So to outline that, for example, if some patient comes to me and they mention that their father had colon cancer at age 40, then 10 years before that is age 30. And because 30 is less than 40, we start at age 30. So whichever one is the earliest is what we would typically use. And we would recommend a colonoscopy every 5 years. Moving towards the right of the chart, you see that if a patient has one first-degree relative with colon cancer, it's pretty much the same screening interval. Again, at least back in 2018, a FIT was listed as a possibility. If you have a first-degree relative, that is now no longer the case. If you have a first-degree relative with colon cancer, you are getting a colonoscopy. That is definitely the preferred test. They do mention here that FIT is a second-line option, but even that has changed. And so anybody with a first-degree relative is getting a colonoscopy. Now, moving further right, this is where we enter into a bit of a gray zone, and there is some differentiating, like different gastroenterologists will screen differently, but we're talking about first-degree relatives with an advanced adenoma or second-degree relatives with colon cancer. For the bulk of these people, we think that the screening guideline does not need to change for them. They are considered average risk, with the exception of these advanced adenomas. And so what this group defined as an advanced adenoma was any adenoma above 1 centimeter, having more than 5 adenomas on one colonoscopy, or any of those higher risk features, such as the tubulovillous adenoma or anything with high grade dysplasia. So if a family member had one of those criteria, some gastroenterologists would start an earlier screening, somewhere between 40 to 50 years old, and again, or 10 years younger than the age of diagnosis of that first degree relative. So for example, if a patient comes to me and tells me that their mother had a colonoscopy at age 50 and they found a big, big polyp, sometimes it takes a little bit of research looking into this, but if we can confirm that that was a high-risk lesion, then that patient could technically get a colonoscopy at age 40. And that's when we would start. When it comes to second degree relatives, we don't think that confers any additional risk, and so we treat them as average risk individuals. To be clear, a second degree relative is somebody like a grandparent, an uncle, a cousin. We get this quite a lot that, my grandpa had colon cancer. They are technically considered average risk. Now, if we approach this, as I said, as on a case-by-case basis, this is a bit of a gray zone. Many gastroenterologists, if they can, they will take a very detailed history. If there are many second-degree relatives with colon cancer, that might affect our indication for screening. So this is where we enter, as I said, a bit of a gray zone, where we approach everything on a case-by-case basis. But somebody with many second-degree relatives might justifiably have a colonoscopy at a younger age and might have a shorter screening interval for those patients. So what has changed since 2018? A few things. Number one is that we've scrapped the FOBT. We've changed it to FIT only, and at least provincially here in Ontario, we've moved to predominantly FIT testing as the first means of colon cancer screening. And so we say that anybody age 50 to 74 who has no symptoms, who does not have a first degree relative with colon cancer, and does not have any personal history of other diseases that might increase their risk of colon cancer, then they fall under this average risk category. All of these patients then will get their first FIT test mailed to them at age 50. They will undergo that. If it is normal, they get a FIT test every 2 years. If it is abnormal, they move towards a colonoscopy. We try to do the colonoscopy within 8 weeks of receiving that abnormal FIT test result. And based on the colonoscopy, we classify them either back into the normal stream if nothing was found, or if a polyp was found, we use the chart that was outlined previously to determine when their next colonoscopy would be. And again, this is for average risk asymptomatic individuals. And so I did like that they classify what is considered average risk. And so again, they mention here that if you have one or more first degree relative, you are not considered average risk. And we would recommend advanced screening for those patients. and it often does require that we take a fairly detailed family history, as I mentioned. But the other important feature is symptoms. If they have symptoms, especially high-risk symptoms, we're talking things like rectal bleeding, weight loss. These would not put patients under this category. On a case-by-case basis, we might elect to do colonoscopies for those patients. We do not use FIT test for asymptomatic patients. Um, uh, sorry, we do not use FIT tests for symptomatic patients. It is not an appropriate screening modality. And so that's something quite important to remember as well. Um, So how does the FIT test actually work? You send everybody who turns 50 years old this lovely package in the mail. It comes with a couple of things, a test kit where we ask them to write the date of the collection, and this is important, it's the date of collection. We get patients to have a bowel movement onto a piece of paper, which is flushable. We ask them to lay that over the toilet. They have a bowel movement. Um, they use the kit to collect a sample of stool, and this is put out to outline what is an appropriate amount of stool to collect. They place that in the bottle, they flush the rest of the stool with the paper, and then they mail this bottle to the government. I tell patients it's your chance to mail your poop to the government. This is done either through Canada Post or it can be dropped off at a Life Labs and it'll be shipped there as well. Um, Now, again, that is for asymptomatic patients. And so if a patient is either high risk, meaning that they have a family history of colon cancer, or if they have symptoms, we would typically recommend that their first screening test be a colonoscopy. And so I'll spend the next little while talking a little bit about the colonoscopy procedure itself. There's been, again, a lot of media attention into movie stars and stuff like that filming their first colonoscopy, and I'm all for it because I think we need to drastically reduce the fear and the barrier and the stigma around getting a colonoscopy in order to help us meet our screening targets. And so I thought I would just go through a little bit of detail about what a colonoscopy looks like, feels like. Again, I'm sure many of you here have gone through it, and you'll tell me, I'm sure, that it's not as bad as people make it seem, but I thought I would just go through some of those details. And so these are instructions that I give to my patients. I tell them that in general, you can eat pretty normally leading up to your colonoscopy. For about 3 days before, I typically suggest avoiding high fiber foods or foods that can remain in the colon for long periods of time. This includes things like corn, beans, seeds, nuts, that kind of stuff. And so I typically ask them to stop about 3 days before. The fiber supplementation, if they are on one, it can sometimes slow the transit of stool through the colon, and so I might ask them to hold off on those as well. During the actual clean out phase itself, it starts the day before the colonoscopy. I tell patients not to eat any solid food whatsoever, only clear liquids. And I also tell them that if you have a choice of liquids, preferably nothing red in color, because red in color looks like blood when we do a colonoscopy, and that can interfere with some of our results. I'll outline two different tests two different cleaning solutions that we use, but I actually have a picture of this chart in my office because I would like patients to know when they need to stop or when they're considered clean. It's when their stool basically looks like yellow water. When they're passing yellow water, that means they're clean, and that means they're ready to go for their colonoscopy. I do tell my patients about medications. Most medications are safe to take even up to the day of the procedure. Certain medications such as blood thinners, diabetes medications does need to be adjusted, and so definitely have a discussion with your primary care provider or your specialist like a cardiologist if you are on any of those medications. The two main solutions that are used, at least here at St. Joe's Hospital, other places have used other solutions as well, but I mostly alternate between these two. There is the traditional PEG light, which is 4 liters of laxative, or Pico Salix, or other forms of what we call low volume prep, which involves less laxative, but still the same amount of clear liquids. And I thought I would just kind of go through the pros and cons about both of them. The PEG Light Clean Out consists of 4 liters of laxative, and that's the big jug that patients talk about. You fill that up with water. It gives you 4 liters of laxatives, and basically patients drink that the day before their colonoscopy. It gets split into 2 doses, whether they do 2 liters at night, 2 liters in the morning, or sometimes 3 liters at night, 1 liter in the morning. Either way, it does get split up because we think that split preps in general lead to a more cleaned out colon. And so follow your instructions closely about that. The last dose, the last amount of drinking is typically done about 3 hours before the colonoscopy itself. There are certain benefits to the PEG light solution, which is why it's still very commonly used. It is a very consistent means of clearing out the colon because essentially patients have to finish 4 liters regardless, and it ensures that for the most part, patients are well cleaned out at 4 liters. It's electrolyte neutral, meaning that it doesn't get absorbed into the body. It should not alter the electrolyte balance, meaning that it is safe for patients with renal disease, cardiac disease, elderly patients. This can often be the safer way to clean out the colon. And it's also the simplest of the methods. It's easy to remember. It's a big jug. They have to finish it at some point. And so there's not that many steps in between. It's the easiest to counsel our patients on. The main disadvantage is the taste and the volume. For any of you who've had to go through this, it does not taste very great. And when you're drinking 4 liters of anything, it can be quite nauseating, but certainly 4 liters of a liquid that does not taste very good typically can cause some nausea, stomach upset, and whatnot. And so for those reasons, I personally have shifted towards a low volume prep. And there are many versions of this, but I use a solution called Pico Salix. It's 2 sachets of powder that you mix into a glass of water. So you mix 1 sachet into 1 glass, and that is the first dose of the laxative. So the volume of the laxative is fairly small. It's only 1 glass. You drink it. But what actually cleans patients out is that after they drink the laxative, they chase that with 2 to 3 liters of clear liquids. The benefit in this situation is that they can drink whatever clear liquids they want, and that is typically better tolerated. They do that once the night before, once the morning of the colonoscopy, and then they come for the procedure. The benefits of this, it is less drinking of laxative, more drinking of other things, but at least it can be whatever they want, so it's easier to tolerate. It does, however, heavily depend on patients taking the initiative to drink those liquids themselves. And so I try to outline for them what 2 to 3 liters looks like. They should lay them out ahead of time to make sure that they are consistent with drinking all of that clear liquid after the laxative itself. And so those are the 2 main solutions that are typically used. Um, I thought I would throw in some pictures of things that we might commonly see during a colonoscopy. On the left side, top corner, these little outpouchings there are called diverticuli. I describe them to my patients like potholes in the streets. After years and years of stool running over your colon, you develop these small craters. They're completely benign. They don't usually cause problems. Sometimes they can, but it's good to identify them and report them in the colonoscopy. In the middle picture at the top, that lump on the bottom is not a polyp, it's a lipoma. And how we can tell that is that it's a fairly flat lesion. The mucosa itself, the lining of the intestine, looks about the same as the surrounding area. It has a bit of a yellowish kind of hue. And when we use our instruments to press up against it, it's soft, it's mobile, and so that's typically a lipoma. The bottom 3 pictures represent colitis colitis, so inflammation within the colon, and sometimes we do see that. But what we're really doing these colonoscopies for is for polyps, and that's the picture on the right-hand side of your screen. This is a pretty simple looking polyp. This looks to be at the very end of the colon in the cecum, so the right-hand side. And there are certain maneuvers that we can do to get rid of the polyp. We may inject the base of it. You can see in this picture, the endoscopist has injected a blue solution to lift the polyp off of the floor of the intestines. They use a snare or a metal lasso to cut off the polyp. And how you know that the polyp is all gone is that you can look underneath and you see that nice blue layer there, meaning that you got the whole polyp off of the mucosal layer. So that's something that we might do, for example, to remove a polyp. And I'm not going to get into too many details about polyp removal, but there are many, many techniques that we do to try to ensure that we get all of the polyp out at once. After your colonoscopy, you will be moved into a recovery area. We ask that you take a few sips of some fluid. We ask that you pass gas, and this is always a little bit of an intimidating part for patients, but we are the ones that actually fill the colon with gas, and so I always explain to my patients that it's clean air, it's air that I put in, and so we do want you to pass that gas out. It generally makes patients feel a lot better. And then for the rest of the day, we tell them not to drive, we tell them not to drink, and we tell them not to operate any heavy machinery, because if they got sedation, they are considered legally impaired. And so you can't engage in those three activities after the colonoscopy. We always counsel patients on what to look out for and reasons to return back to the hospital if they have severe or persistent abdominal pain, if they are unable to pass the gas and they have a big swollen belly, if they have any fevers or chills, or if they have any bleeding lasting more than 24 to 48 hours, that's a reason for them to come back to the hospital. I do counsel patients depending on what I do. If I take off a polyp at the very bottom of their colon, I tell them that sometimes a little bit of blood can happen. That's a normal part of undergoing a polyp removal process, but bleeding lasting more than 24 to 48 hours, they should present to medical attention. I've already presented this chart in my first talk, but based on what we find and the number and the type of the polyps, we may suggest that they come back anywhere between 5 to 10 years for their next colonoscopy. Anything more high risk than that, or if I felt like I wasn't able to completely view the colon, I might choose to bring them back even less than 5 years, either 3 years or at the 1 year mark for a repeat colonoscopy. I only have a few slides left, and I'm going back to data because I think that data and pictures like this speak much louder than words than I can. But I wanted to talk specifically about the uptake of our screening protocols, because it's nice that we have these protocols in place, but is it actually being applied? Is it actually being used, and are patients actually presenting for screening? And I think this is another important area on top of advocating for changes in policy. It's advocating for ways that we can implement these policies at a consistent level across the provinces. And unfortunately, we're not doing very well on that front either. So this is data from 2024 looking at how many people actually presented or how many people are actually following the screening criteria, meaning that they did get their first FIT test at age 50, and they are continuing to get FIT tests every 2 years, and that they are presenting for their colonoscopy if the FIT test is abnormal. And the national average currently sits at just under 50%. That means half of our population is not following the guidelines. Either they're not getting their initial testing done at the right age, they're not presenting for the colonoscopies if their FIT tests are positive, and that's a pretty scary number to think about. Now, I should mention that one trend that we are seeing is that a lot of times, unfortunately, it's our patients at the more marginalized populations, those either at a socioeconomic disadvantage, patients who are away from a tertiary care center. These are the patients that are falling through the cracks. And I think we definitely need to do more to advocate for a screening uptake in these populations. And that's an area of active research and active development within the colon cancer world. I should point out that Ontario, my province, sits below the national average, which is a little bit concerning. Um, and why I was shocked by that number, and so I looked a little bit into why that might be the case. And I think one thing that we're still learning about the after effects of right now is COVID. COVID has affected cancer screening universally across all different kinds of cancers, but I think it has affected colon cancer more than any other, just because of, at least in terms of colonoscopies, you would have to go to a hospital to get a colonoscopy or these centers, and for a long time, we were not able to do colonoscopies safely in the peak of COVID, just because it was considered an aerosolized generating procedure. And so I think because of this, among the cancers, colorectal cancer screening was hit one of the hardest by the COVID pandemic. And you can see this in this chart here, comparing breast cancer and cervical cancer to colon cancer. We have data across several provinces, and there has been a universal decrease in screening across the provinces. But sometimes it is quite startling. We're talking 50 to 60% reductions in screening during the COVID era. And I think we are just starting to see the ripple effects of that now. This report put out by the Canadian Cancer Society is called "Living at the Crossroads of COVID-19 and Cancer." It's an excellent read. It really outlines the challenge that we have facing us to make up for what was lost during COVID. They document that even a 6-month delay in the colon cancer interruption can lead to 1,000 more cases of late-stage diagnoses. It leads to almost 1,000 deaths, and a huge impact of potential life years lost. And this is just 6 months of delay. So it really outlines the importance of presenting on time at the recommended screening intervals for either a FIT test or a screening colonoscopy. And again, I feel like I have to end on some good news. This was another study that I found published in 2024, comparing looking at the same effect, looking at the impact that COVID had on colon cancer screening, both here in Canada and comparing us to a similar country, Australia. And so here in Canada, we think that COVID probably caused about a 40% decrease in our screening intervals. We're probably going to see about a 10% decrease in our ability to diagnose colon cancers, and a 5% decrease in those then who will move on to surgery. All of this leads to about, they estimate, 1,820 additional colon cancer deaths that we will see in the next 10 years, which is a 1.9% increase compared to baseline. So what's the good news in that? The good news is that they've used predictive models to see what it would look like if we were to implement additional measures, advocate for screening, ramp up our colonoscopy centers. If we were to do all of that and have a temporary 5% increase in our diagnostic ability to treat and detect early colon cancers, we can drastically decrease that burden. They think with even just a 5% increase in these diagnostic capacities, we can reduce our deaths to just over 1,000 over the next little while, which is a huge improvement. Compared to Australia, we stand to benefit the most from this, just because of how distributed our centers are, and our current FIT screening program is quite robust. And so we think that if we can ramp that up even by 5%, we can drastically reduce the additional colon cancer deaths that are made during this time. And I think that that's a hopeful message, because 5% is not that much. all it takes is for everyone to work together for events like this to spread the word, for family doctors to become aware, for gastroenterologists like myself to continue with screening and to continue to ramp up our ability to screen people. And 5% is really not that much, but it can really make quite a big difference over the next 10 years. And so I definitely look forward to ways that we can continue to address this unmet need. Um, and with that, I'll end my second talk. Again, thank you all very much for your attention. I hope this encourages many of you to continue on with screening and advocating for that among your family and friends. So thank you very much for your attention.
Thank you so much, Dr. Wang. That was absolutely incredible. Both sessions were phenomenal. Thank you so much to our silent viewers. A reminder, please do head back into the lobby to join the next session, which will start around 12 o'clock. So you've got a little bit extra time to get a little more rest and maybe a quick bite to eat. To our coaches, please do move into the backstage and we'll continue on with our questions. See everybody soon.